Hi, everyone. We are almost done with week 7. Wow, this is amazing. But anyway, just wanted to say that Janice had sent some emails and asked about the competitions, and that some of the t-shirt contest is going to be judged by Wisconsin Emergency Management, and so that we'll have that done next week. Okay, and then also it was the t-shirt contest, and then the posters. So if anyone wants to, if you haven't done that yet and want to submit anything, just send me an email with the attachments, and we will be sending those off next week then, and by the end of next week we should have a decision, okay, at the latest. All right, so go ahead, Kim.
All right, so welcome to Thursday. Thursday's our Cath Lab presentation. I am going to go ahead and get it started. If you have any questions throughout, as always, please remember to just go ahead and enter them into the chat feature. I'll try to make sure not to accidentally mute myself and then mute the presentation like I did earlier in the week. This is all kind of new, using all these new tools and stuff. So yeah, I hope you enjoy the presentation, and then feel free to put any questions in the chat box. All right, so when I get it going, give me a thumbs up if you can hear it once it starts.
Hi, my name is Katie Kogutkeiwicz. I am one of the nurses at the Cath Lab at Children's Hospital, and Judy Mattice, one of our RTRs, and myself have prepared a PowerPoint presentation regarding congenital heart defects and the things that we do here in the Cath Lab. We were hoping that this information would kind of help tie some of the heart information together by giving you some idea of what we do in regards to heart defects here at Children's Hospital. So please sit back and enjoy.
Hi, welcome to the Have a Heart presentation. This is Katie Kogutkeiwicz and Judy Mattice. We both work at Children's Wisconsin in the Cardiac Cath Lab. All right, this slide gives you a demonstration of what the normal heart looks like. There are 4 chambers to the heart. 2 on the right, you have a right atrium and a right ventricle, 2 on the left atrium, left ventricle. The right side of the heart receives deoxygenated blood from your body. The left side of the heart sends oxygenated blood out to your body. Typically, when you hear about problems with a person's heart, we tend to think about adults and coronary artery disease. Often when people talk about coronary artery disease, they say somebody has had a heart attack. This means that the coronary arteries that deliver oxygenated blood to the heart have blockages in them. When we talk about kids and heart issues, we most frequently talk about congenital heart defects or congenital heart disease, which we call CHD. Congenital heart defects are problems with the heart structure, and they are present at birth. Occasionally they can form after birth, but generally they're formed in utero when a baby is a fetus. Common examples include holes in the inside walls of the heart and narrowed or leaky valves. In more severe forms of congenital heart disease, blood vessels or heart chambers may be missing, poorly formed, or in the wrong place. How common are congenital heart defects? Congenital heart defects are the most common birth defect. Congenital heart defects occur at almost 1% of births. Nearly 40,000 infants in the U.S. are born each year with congenital heart disease, and approximately 100 to 200 deaths are due to unrecognized heart disease in newborns each year. These numbers exclude those dying before they're diagnosed. Congenital heart disease are as common as autism, and about 25 times more common than cystic fibrosis. Approximately 2 to 3 million individuals are thought to be living in the United States with congenital heart disease. Because there is no U.S. system to track congenital heart disease beyond early childhood, more precise estimates aren't available to us. Surgery is not often a cure for congenital heart disease. Quite often, the surgeries that are done are what's called palliation, or helping to improve the quality of an individual's life. Defects such as ASDs or VSDs are able to be fixed with surgery, but again, the majority of surgeries are just done to improve quality of life. Often people wonder what the cause of how is congenital heart disease caused? Only in about 15 to 20% of the cases are they known to be related to a genetic condition. Research has shown that potentially environmental exposures may be related to risks of having congenital heart disease, including a mother's diet or certain chemicals and medications that a fetus is exposed to when a mother is pregnant. Maternal diabetes is also a recognized cause of congenital heart disease. A baby's risk of having congenital heart disease, however, is increased 3 times if mother, father, or a sibling has had a congenital heart defect. The first cardiac cath performed at Children's Wisconsin was well over 40 years ago. Today, these slides are pictures of our current cath lab. The 2 big C arms are the X-ray cameras that help us take images of the heart in a front to back and a side to side views. Pictured on the screen is the current cath lab at Children's Wisconsin. This current cath lab opened last June and cost roughly $5 million. On the screen, you can see there are 2 what looks like big screen TVs that have pictures of us on them. Those are actually our monitors, and we are able to turn on videos for kids when they first come into the rooms. A lot of times when kids come into the rooms, they're kind of nervous or anxious because they're being separated from their parents, and so we'll put on videos to distract them. Once we start anesthesia and they start to fall asleep, then we're able to switch over to our monitors so that we're able to monitor their vital signs, which would include their heart rate, their blood pressure, or their oxygen saturations. In order for us to study the heart in the Cardiac Cath Lab, we use what's called a sheath, which is similar to a large IV. And depending on which side of the heart we want to go, we need to access either we can also use radial arteries, or we can use a big vein in the neck. And that we have to place a catheter through those sheaths and travel up the bloodstream and place the catheter into the heart. And that once we're in the heart, we can measure pressures, we can test the oxygen level of each chamber of the heart, and then we can inject contrast into the heart so we can actually see the blood flowing through the heart. One of the procedures we do in the lab, in the cath lab, involves closing an ASD. So an ASD is an atrial septal defect, which is a hole between the left and the right atrium. If ASDs are left untreated, they can actually lead to heart failure, or where the heart becomes very big and very overworked. ASDs were originally only closed during open heart surgery. We now have the ability to close them in cath lab utilizing a vein in the leg rather than having to open up the whole chest for open heart surgery. It's nice for patients because typically they're able to just stay overnight and then able to return to normal activities within 3 days. When we close an atrial septal defect in the cath lab, we utilize our X-ray equipment imaging, and we also use TEE, which is a special ultrasound probe that goes down the esophagus and can look at the heart internally. We place what's known as a sizing balloon up and through the hole inflate the balloon with contrast so it's visible on an X-ray. And then the DE probe, the ultrasound probe, shows us if there's any more blood flow. Once we've determined there's no blood flow between the right atrium and the left atrium, we do measurements to see how big the hole is. In this image, if you click the arrow on the lower left, you'll be able to see the cardioform device being extended out into the left atrium and the heart. The first disc is there. The device will be pulled back. The TEE, the ultrasound probe, is going to let us know that we've hooked the device onto the septum. And once we show there's no blood flow, the second side on the right side of the heart will be deployed. Picture or angio shows one of the cardioform devices once it's deployed. By deployed, we mean that we have released the catheter and the cable that held it in place. If a device is positioned wrong, if the cable is still attached, we're actually able to pull it back in and pull it out of the body. Once the device is released, it's there to stay. So it's important that we know that the device is sitting in the right position. Arteriosis. Everyone has a PDA before they're born when they are a fetus in utero. The purpose of a PDA is to allow the heart and blood vessels to grow and receive oxygen before the lungs are actually used. Generally, after birth, the PDA closes. In preemie babies, babies born too early, often these PDAs stay open, making it difficult for the lungs to work properly, so they need to be closed. Pictured below is a preemie or a baby that's been born early, and also pictured is our piccolo device, which is sitting on top of the dime. The device that's used to close that connection is really tiny and stops blood flowing from between the aorta and the lungs. It's really important in tiny babies whose lungs aren't developed to stop all that extra blood flow so that their lungs can heal and grow. The new device has allowed us to close PDAs on babies as small as 900 grams, or just under 2 pounds. And again, that device itself, that's the actual picture of it there, and it's that much smaller than a real dime. Okay, below you can press the play button and you will be able to see that there's a catheter going up the right side of the heart and across the PDA into the left side, the descending aorta. The black contrast that you see is just that. It's contrast that is identifying where the PDA is and how big it is. The screen on the right shows the measurements. We use that measurement to determine the size of the device so that we can plug the PDA safely and cause that blood flow not to happen from the aorta to the lungs. If you press play and look closely, you can see the small device that's being deployed in that PDA between the aorta and the pulmonary arteries. PDAs are also found in older children and occasionally young adults. A large PDA device, larger than the piccolo, is needed for this and such as a PDA included. A common problem we see in cath lab is problems with kids with their valves. We have valves in the heart to help control the flow of blood through the heart. There is a valve called the tricuspid valve, and that's between the right atrium and the right ventricle, and then another valve between the right ventricle and the pulmonary artery called the pulmonary valve. On the left side of the heart, we have the mitral valve, which is between the left atrium and the left ventricle, and then the aortic valve, which is between the left ventricle and the aorta. Again, these help control the flow of blood and the volume of blood in the heart. When a valve is leaky, we call it insufficiency. When a valve is narrowed, we call that stenosis. We can treat valves in the cath lab that are stenotic by forcing them open by inflating a balloon inside the valve. Okay, if you click the arrow below, you'll be able to see the image in motion in the heart beating. Have a catheter placed into the right ventricle of the heart. So it is on the deoxygenated side of the blood. The purpose of the right ventricle is to send blood to the lungs. And the left picture on the right shows the leaflets of the pulmonary valve. And it is narrowed. So we are doing measurements so that we can take a balloon and open up that valve. To put it in layman's terms, if you think of your garden hose and you're watering the lawn, if you kick your hose, what's coming out the end of the hose? Maybe just dribbles of water, but there's a lot of pressure building up on the other side of the kink. And that's kind of what's happening here. The right ventricle has a lot of pressure in it, and it can't send the blood it needs to send out to the lungs to be oxygenated. The arrow below the picture on the left, it's going to show one of our balloons being inflated across the pulmonary valve. What this does is it actually pushes back the walls of pushes against the walls in that area and kind of pushes on the valve to open it up. The picture on the right then shows us injecting contrast into the right ventricle and shows the flow of blood across the pulmonary valve into the pulmonary arteries and into the lungs, showing that blood flow has improved, and now that deoxygenated blood is much more easily able to get back to the lungs and be reoxygenated so that it can be distributed to the rest of the body. Sometimes the valve cannot be fixed with ballooning alone, and the valve needs to be replaced. This was traditionally a surgical procedure, but now for certain patients, this can be done through a vein in the leg in the Cardiac Cath Lab. These are two of the valves that we sometimes deploy. Picture below is a melody valve that's being inserted. So a melody valve that goes in through the vein in the leg and then is mounted on a balloon. And we use what's called an inflator to put pressure into that balloon to blow up the valve actually, so it adheres to the walls of the pulmonary artery. The inflation device is kind of like a pump on a bicycle tire, if you can think of it that way, where you push and pressures from PSIs are increased and it pushes against that balloon. Then when we want to take it down, we turn the inflator and we take the pressure away, kind of like if you would pull the air out of the tire. If you hit the arrow on the left, you'll be able to see, once again, contrast filling the right ventricle and extending out into the pulmonary artery. On the picture on the right is where we once again need to take measurements so that we are sure a one-size valve will fit into the vessel. If we put too large of a valve, we could cause a rupture in the patient to bleed. So this is why we take these measurements. If you press on the arrow below the picture on this slide, you're going to see a stent being inflated. So a stent is a metal tube that a lot of times we'll put down before we put a valve in. And it's kind of like a piece of scaffolding. It just really provides structure and support for the valve when we place the valve. So like I said, we will put the stent in first many times and then go in afterwards with the valve. This is a picture that demonstrates the stent inflated. The balloon is no longer inflated. It has been withdrawn, and we have a landing zone for our valve. This angio or picture that we are taking actually shows us positioning the melody valve and then using the balloon again that's on the inside to inflate the valve within the stent. You can click on the arrow to the left and you can see that we're injecting contrast. The valve is now in place, and you will notice that there is no backflow from the pulmonary artery back into the right ventricle. The valve is working. Kids with congenital heart disease sometimes have blood flow that tends to be different than normal. Because of this, they can develop extra blood vessels, which can in turn decrease the oxygen levels in their body. It's kind of like if you were going down the road and the road looked crowded, you would take a side road, or you would make your own path and get out and walk around. That's what happens with their blood vessels. They form these extra blood vessels. And what happens is the blood vessels don't always end where they're supposed to. So sometimes they take deoxygenated blood and bring it back to the oxygenated parts of the body. What happens with that is then it lowers their oxygen saturation, and the blood that needs to be reoxygenated doesn't get reoxygenated. So what can end up happening is it makes them feel very tired, more tired when they exercise, and then they'll appear kind of blue in color. These vessels can be plugged, though, to keep the blood flow on a more efficient course back to the heart and lungs. Okay, if you click on the arrow on the image on the left, you will see contrast entering into a blood vessel. And if you look at the image on the right, you can see that we've demonstrated an extra blood vessels. There, we take measurements of the blood vessel so that we can choose the correct device to plug that. The picture on the left, or again, angio, shows an injection in the extra blood vessel. And then the picture on the right, if you look carefully, it almost looks like two Hershey's kisses together, actually three. And that is what we call a plug. And it's one of the devices that we use to get rid of or to plug those extra collateral blood vessels. Arrow below, and you will see that we're injecting contrast where that extra vessel was, and we have totally approved it. Another issue that we address in the cath lab is issues with rhythm problems. The heart naturally has a pacemaking system that is in charge of sending out signals which help the heart to know when it has to beat. When the heart's natural pacemaker has a dysfunction or isn't working right, the signal it sends out might become kind of erratic and either be too slow or too fast or just too irregular to ensure that the heart is contracting the chambers of the heart on a regular basis. When this heartbeat becomes too erratic, it's referred to as arrhythmia, which is an abnormal rhythm of the heart. One of the things that we can do to help solve this problem is put in a pacemaker, which is a small device that's placed in either the chest or the abdomen, depending on the size of the kiddo, to help control the abnormal rhythms. And this device uses those electrical pulses to prompt the heart to beat at its normal rate. Another device that can help the heart and involves the rhythm of the heart is called an ICD. When someone suffers a cardiac arrest, we use an AED to externally stimulate the heart back into a rhythm. An ICD is similar to that, but it's an internal device that watches over the person's rhythm. If the ICD detects a rhythm that is irregular and could cause person to go into cardiac arrest again, it can shock the heart back into its normal rhythm. Okay, so now it's time to test your knowledge. We've listed 5 questions, 2 multiple choice and 3 true or false questions. The answers are contained obviously here in the program that we have done. So feel free to try and find the answers to those. And again, you can refer back to the slides or to the video. And then the answers are on the next page. Thank you for taking the time to listen to this presentation. If you have any questions about it, feel free to reach out to us here at Children's Hospital. We are in the Cath Lab, and we are more than happy to answer your questions. Have a great rest of your week at Red Camp, and we hope you learn all kinds of great things. Thank you.
All right. How did you guys do on the test? Did you get most of the answers?
Yeah, most of them.
Most of them? Yeah. Which one tripped you up, Jordan?
The one where it was like, does everyone have the whatever it was?
Yeah,
like
the
at birth?
picture, like thing as a fetus. Yeah.
Yeah.
Yeah, the key there was as a fetus. So, because everybody has that, but like most of the time for most babies, it'll close up. And like she mentioned, like preemies especially might be more prone to not having that close up and where they have to go in and close that for them. So let's see, I'm trying to see here what's in the chat. Yep, I saw it, Rayanne. You got the first two answered good. They were correct. Do you guys have any questions or thoughts on this topic? I know it's 1 o'clock, so a couple of you may have to go. But did anybody have any thoughts or questions? It was a lot of information, a lot of stuff. I liked actually, I'm glad that they showed pictures of their cath lab because I thought that was interesting to see what it looks like on the inside. So not something that you always get to see is like the inside of their spaces. So yeah. So I don't know that, I think MJ might be on another call at this point. Another meeting. She had a 1 o'clock meeting as well. If we don't have anything else, I'll just remind everybody like to make sure to keep taking on those challenges, any like the t-shirt challenge and any other challenges that have happened, you know, from weeks 1 through week 7. Please feel free to just be part of that and sharing information with MJ. Great job to you guys who like took up the CPR challenge this week and have developed something, a PSA or a poster or video so far. That's really exciting to see you guys to step up and do those things. And then tomorrow will be the last day for this week of camp. It'll be myself and Allie Thompson from Children's Wisconsin, the director of the Project Adam program. And so we'll kind of wrap things up. Hopefully we will have a little bingo card that we'll send out. If it doesn't get sent out to you tonight via email, then you'll have it by tomorrow morning. And just print out one of the cards and we'll follow along and do a game, and whoever gets bingo first will win a prize. So that's kind of all we have for today, unless you guys have any questions or comments or anything you want to share. I see lots of no's. Okay, so thank you everybody, and we'll see you tomorrow. Have a good rest of the day.
Thank you, you too. Bye.
Bye.